Introduction. Today I'll be talking about challenging situations in ICL implantation and as a separate second part of planning clear lens extraction. So first, going to the IPCL, there are many complications which are there, which are also listed here, like ICL rotation, ICL dislocation, night vision symptoms, pigment dispersion. So many things can happen, especially we are more worried about the cataract formation up leading to RD and endophthalmitis. So in this case, we have a 20-year-old female who had a stable refraction for 3 years. Her refraction was in right eye minus 20 diopters, in the left eye minus 21 diopters, and her white to white was 11.15 millimeter, and the left eye 11.20 millimeter, and her AC depth was adequate, anterior chamber depth 3.61 and 3.59. This is the biometry printout. In this, you will see that you will remember that in star ICLs, the hole on the top is on the right side. When you are implanting, you have to make sure that the hole is on the right side. In the biotech, in ICL, it's on the left side on the top in biotech IPCLs. And in this video, I want to show you so this is you have to be very careful when you are doing ICLs, because these patients have come to you with, even if though it was minus 20, she had 6.6. So even when you are making an incision with your MVR, you have to be careful that you don't hit the lens. Even when you are making the main port, you have to be careful that you don't go and hit the lens. Loading is a very integral part of this ICL, this thing. Star is a little even more challenging to load it, but biotech ICL is much more easier. You have to make sure that none of the haptics are stuck when you are folding, and then you push a little bit forward, and then you go ahead and implant it. When you're implanting, you have to make sure that the hole is on the left side and not on the right side as is in the star ICL. So once again, it's just increased a little bit, and see carefully that when the top left hole, which should go on the left side, actually turns around and goes to the right side. So, and actually it had to come on the left side. So now I am trying to, now I try to tuck it, I still haven't realized that I have put it upside down. So when it doesn't happen, then I am a little worried, and then I realize that it's looking like a ball, and I have put it upside down, and now I need to remove it. And then what I did is something I want you to know that you should not do. This is what you should not do, which I'll be showing, which I just turned around, flipped it around, and put it in place. And by God's grace, even till today, she's doing well. But this is what you should not do. Do not turn it around inside the anterior chamber. You can hurt the endothelium, you can hurt the anterior lens capsule. And this was a toric which was put in place. So actually, I'm grateful to Dr. Anaga Harur. She has lent her this video of when you put this ICL inside and you realize that you have not put it in properly and you have a difficulty, then you just go ahead, and once you have put it in place and you realize that this is not the correct placement, then instead of turning it around, so once you have put it in place, then it's very simple. You just pull it out like this instead of turning, what I had showed you earlier. And this is the picture of the girl who we operated with minus 20, and now she's like this. Now, planning a clear lens extraction, there are several articles which you'll read that clear lens extraction for patients who are fit for LASIK, unfit for LASIK, and those are the patients who we choose for clear lens extraction. In this particular case, we have a 24-year-old female who had a stable refraction for 6 years. Her right eye power was minus 8 and left eye was minus 6, and she had 6.6. And this is still in the range of doing LASIK. Her corneal thickness was also good, and her anterior chamber depth was 3.18, but her white to white was 10 millimeter, and which is why we decided of doing clear lens extraction with a trifocal IL, because she is young, she will lose her accommodation after removing the lens, so a clear lens extraction was planned. So this was her topography, and this was I was putting a toric trifocal inner eye. So this was the alignment, and this is the video for the clear lens extraction. You have to be very careful when in these patients the anterior capsule is very rigid. So if it runs out in young patients, then the placement of the premium IOL will also not be good. And these patients will be living for another 70 to 80 years. And then a non-centered trifocal IOL will give her more problems than any comfort. So I make a nick, and then I always use Utrata forceps so that I'm in control, it doesn't run out. And it's very important that for these premium IOLs that you make a central round rhexis properly. You have to always keep the centrifugal force towards the center, because they have a tendency to keep running out in these young individuals. Once you have completed the rhexis, you have to be, it's like a routine cataract surgery. You go ahead and do the hydrodissection, and it's like you cannot afford to have a complication in such cases. So nucleus is hardly there, so you just have to remove the cortex over there. So you can use your phaco probe also to remove all the cortex which is there. And once you have done that, then you go ahead and implant you have to be carefully removing all the cortex. And at this point also, you don't want that the haptic should break, or you have not put the intraocular lens properly inside. So you have to be very careful when you are putting the haptics. Young individual has come to you with 6x6. You want to send her home without glasses with 6x6, and you go ahead and implant these lenses. Some of the lenses by AdTech are also without any financial interest. They have these grooved haptics which keep the toric IOLs in place, and you just remove all the viscoelastic, and it's very important to remove the viscoelastic from behind the IOLs also in these premium IOLs, and then you put it in place. So this was the patient, and now she is very happy, and she has trifocal in both her eyes now, and she is on top of the world. Thank you so much for your patient here.
Thank you, Dr. Satyajit, for excellent talk. As you said that you should never try to flipping the lens inside the eye, because whatever the endothelial count, because all these patients need to come for a long-term follow-up, and also endothelial count tend to decrease year by year. So all these phakic lenses are designed in such a way that even with the wound of 2.8, you can remove that, you can reload it, again inject. Maximum it will take hardly 5 to 8 minutes. I think you have given the good pulse.
Yes.
Congratulations.
Thank you very much.